Hi guys, my name is Roger Markin, and I'm on the board of directors of the Myositis Association, and I just took over the chairman position of the Programs and Services Committee. Okay, so over the next few days, just please stop me, talk to me, whatever, I want to hear from you guys, how we can, improve things. And don't ask me about improving lunch or breakfast, I can't do anything about that. Please, hail me, and thank you very much for coming to this particular session. And we're gonna, let the gentlemen introduce themselves. But the topic, about the IVIg, part of it. We're joined by three gentlemen. Thank you for making the time for us. And we'll start with on the further corner. You guys want to do your own introductions? Okay, we'll start with you.
Hi, thank you for inviting us. My name is Myositis. I'm a pharmacist. I'm the Chief Clinical Officer of Kava Fusion. So we are a home infusion company. As my tailor-made from lunches here. We have 7 pharmacies: LA, Chicago, Boston, Philadelphia, New Jersey, Dallas, and Florida. Actually, the one that's in Florida is under water right now. So we do IVIg, we do other therapies, patients in 39 states right now. We have our own nursing services, and we have several hundred patients getting IVIg. And so when Rob asked if we'd be interested in participating, I thought it would be good to spend some time in this group. We have lots of patients with these several diseases we're talking about here, so I'm glad to be here, and I'll give you whatever experience and questions you have. I've been doing this since 1990, so we've done a lot of patients since then. Maybe 5,000 IVIg patients since then, maybe 5 or 7 million grams of IVIg in that time. So a lot of experience, but it's just from my point of view. So I'll turn it over to Ron.
Good afternoon. My name is John Mann with Solio Health. I am a registered nurse and a respiratory therapist by profession. About 24 years in specialty pharmacy or infusion therapy. IG has been a big part of that. We specialize in IG therapy, also some other acute TPN, antibiotics, and therapies like that for other diseases. Let's see what else. Currently, we are servicing patients in all 50 states. We have pharmacies in 18 states. Too long to list all of them now, and we're continuing to grow. So look forward to taking some of your questions and appreciate the opportunity.
Thank you. My name is James Sheets. I am a pharmacist. I'm also the CEO and co-founder of CSI Pharmacy, or Clinical Specialty Infusions. Thank you to the Myositis Association for inviting me. This is incredibly nice. My first myositis conference. I'm excited about that. First time in San Diego. I haven't got to see much of it yet because the conference has been so busy, but got plans to go do that tonight. Also think I see a lot of familiar faces out there. Some of you are patients. Some of you are people I've seen at KID meetings before. Others I just met at this conference, and you've been grateful enough to share your story with me and in return us talk about that and be part of your life. So thank you. I'm a pharmacist, as I said. I kind of found my interest in neurology in pharmacy school. My first year, I'm a real type A personality, and I had my first semester of finals. Well, I was stressed out because I'm always afraid I'm going to fail at whatever I'm doing. And I stayed up for 3 nights just studying for it. Took the finals, all that went fine. The next morning, after the last final, I woke up, went and looked in the mirror, and the whole right side of my face was paralyzed. And it kind of alarmed me. Had no idea what it was. Went to the ER, and it turns out it was diagnosed right away as Bell's palsy. Fortunately, it's generally kind of a temporary condition, but we did get the right treatment, and took 5 months before it returned. And I only partially returned it, mostly all returned, so I'm real grateful for it. But that kind of got me interested in neurology. Graduated pharmacy school in 2000. Right out of school, the first thing I did was go to become an IV pharmacist. About 6 months after graduating, went to IV pharmacy. A few years into that, I took care of my first IG patient, and it was autoimmune disorders with neurologists. It was mainly CIDP and myasthenia gravis. That time I'd never heard of myositis, but something that really was piqued interest in. And so in 2012, we started CSI Pharmacy with the idea we would specialize in immune globulin therapy. And so that's been our goal. As part of that, we've been active in that Immune Globulin National Society that's meeting in Vegas. I'm part of the standards committee there for writing standards for IG. Really looking forward to answering any questions you have. We've got a great group with us here too, so thank you.
So, you know, I met with all three gentlemen before we started, and they thought the best format would be for you guys to ask questions. Is that fair enough? Okay, what I'm going to do is I'm going to turn this chest.
Did you hear that?
Okay. All right. Starting with a question. Anybody have a question? Wait for the mic if you do.
Hi, my name is Martha Corbier from the Virginia area. I've had second infusions of IVIg. What I wanted to ask you, all three gentlemen, is what are the processes of your pharmacies? Does the patient have to be involved in being the one to get the nurses, make sure that they get the medication, and up until the last moment not know what nurse is coming and so forth? And that's the question to all three, please.
Who wants to take it?
My question to you is, are you having to do all those tasks yourself?
Exactly. Yes.
Okay. That's not good.
It's stressful enough as it is, right?
Absolutely.
You need to find another company. It's probably any one of the companies that are here at this conference. But you know, the company should be acting as an advocate for you as a patient, and a pharmacy has plenty of resources and experts that can do all of those things for you and should be doing. Your insurance.
And they're part of Walgreens now, so it's amazing what, you know, being a new one in that situation, it was, you know, option care. So, but anyway, so I appreciate that.
Sure.
Yeah.
Thanks.
So I agree with John. Let's call David. John. The standard in our business would be that you wouldn't be involved in any of those things. You'd be counseled and consulted to make sure that you hadn't been with that agency before. But you know, the fact that you would be asking the questions is somewhat embarrassing for our business to begin with. So you should be expecting that the pharmacy company would be getting insurance authorization for you, working through those details, finding the nurse agency or finding the nurse for you, shipping the drug and supplies to your house. So basically, you should feel no different than if you're in the hospital, except you're at home. And in the hospital, you would never find your own nurse, you never find your own drug, and someone would do all that for you. So, as John just said, I think that the company, and I don't know, I used to own part of an option care back in the early 90s when option care was an individual franchise, and then it got bought by Walgreens, and then Walgreens sold part of their operation to Boots Pharmaceuticals, and they pulled out the option care name that we inherited years ago. So it's a complex situation, and maybe the your office is not doing what everybody else does, but that was probably very unusual that anybody would be asking a question like that in 2017 in this industry. So sorry to hear that very much. Do you want to make any comments on that?
Yeah, so I just wanted to follow up on that, and what I would say is that I've run into that quite a bit. It's something that is kind of embarrassing when you run into it. There's a lot of great home infusion companies out there. There's no doubt about that. IG therapy is quite a bit different. Its coverage is dependent a lot on the diagnosis and the different payers. The nurses need to be specialized and experienced in what they're doing to know how to give the infusion, how to notice reactions. So my recommendation is to find somebody who specializes in IG. I think that makes a big difference. Someone active in like the Immune Globulin National Society, As Mike said, pretty much anyone here has experience working specifically with IG, and there's others out there as well, but it is different, and it is something that you're going to want to work with someone who has experience in it.
Anything else?
Hi. So I was just wondering, how does the process work, and how long is the process to get it approved? And then is it cheaper than going to, like, I go to my rheumatoid arthritis and I sit in a room full of 20 other people with curtains right? Like, so is it cheaper? Because I know I pay almost $3,000 a month for it. So I don't know how that works for you guys.
Yeah, so I can start that off. Whether or not it's, in general, home infusion is less expensive than hospital infusions or physician office infusions. Again, it's something that does vary greatly from insurance to insurance. So we really have to look specifically in your case to see, in terms of getting it done in the home. It's easy to set up. The process was your question. How long does it take? Well, that also varies, but there's been times that we've gotten orders in and the next day infused. So it's not always a long process to get authorization. Sometimes it is, and that's where having an experienced company is going to help again, because you need to know how to fight the insurance companies to get that approval. I would say on average, 5 to 7 days is pretty confident that you, on average, will be infused within that period of time if you get a new order. But it's very specific on the payer.
So I would echo what James was saying here. The time period varies. We've done this fast as a day, and sometimes it's a month or more, and sometimes the patient wants to go on vacation before they start. So a lot of things are happening. But when we get a new patient, the standard should be that we analyze your insurance benefits, we analyze the potential options for you. Should you go to an infusion center? Should we get it home? Does your insurance benefit cover both? If it does it pay the same rate at both places? Does it charge you a different amount out of pocket at one place or the other? So we find several insurance companies in the U.S. now, they don't want to be done in the doctor's office or hospital because they think it's more expensive. So they're going to make your benefits worse there, so they'll make you want to go home, so that your home will be relatively less expensive. Now your $3,000 a month part is quite common. If you think about the average person getting 150 grams a month, maybe that's $100,000 to $200,000 a year. If you take 10% of your out of pocket, you get the 15 or 20 grand a year as far as your out of pocket. And then depends if you have a secondary, supplemental, all those things. If you're a young person, you can't have any Medicare issues unless you're disabled right now. So it's a triage. I mean, when I think about it, when I used to be ER pharmacist before this started, the people would come in and this guy's arm is hanging off, if we don't do surgery, an hour's going to die. So he gets worked on right away. If somebody else comes in with a broken finger, it may take an hour or 2 or 3 more to see it. And that's what I think we do when we get a new patient like you, we try to figure out what are all the issues we're facing clinically, operationally, financially, where you live. We have a lot of patients we get, just like you guys, they live in a place where there's not a lot of people. And when we try to find nursing or try to find alternatives for them, it becomes challenging because they don't have the metropolitan place, and so sometimes that can take longer. And then as far as insurance goes, most people in insurance they get is relatively by accident, either come to their job or your parents or by pick it on purpose. And those insurances are dramatically different. So one might cover certain things in the home, not things in the doctor's office, or vice versa. So for someone like you, as James and John both echoed, you should either call your current company, your insurance company, and say, what are my options? And ask what it is that you could do other than what you're doing. Now, you may find that being a rheumatology with 20 other people is fine. It may be like a social. We made an infusion center one time, like 10 years ago, and I specifically put the 6 chairs facing away from each other, and I put TVs in them and gave everybody a separate thing. And I came the next day, they're all flipped around, they're all talking, like having a kumbaya on a barbecue in the middle, and I didn't expect that. So some people really like the concept of the socialization, and some people may like more not having family or be at home. But other people may find that having a nurse in their house for 6 hours or 5 hours may be challenging as well. So it's all depends what you want to have in your life. If you're young and busy and working, then obviously that has an impact. So your insurance company should give you the first cut of all the options you have, and then you can pick from that, including changing insurance companies if you don't like that eventually. So that would be my advice to you, is that if you're happy with it, except for the 3,000, then that's one thing. If 3,000, then you need to look at somebody to help you figure out what financial assistance is available, either from the people who make the IVIg, or several 501c3 foundations, like non-profit foundations, where you have money available to patients who qualify based on the disease they have. So if you give me a call, and I'll give you a list of them. We can figure out which ones have your disease listed, because many of them have 20, 30, 40 diseases, and many of them are very rare, much more rare than what you said you have at times. So there's lots of options, and it's just a matter of how much support you have and where you're going to get it from to figure out what else you can do, if anything. Maybe what you have is the best you're going to get right now.
Did that answer your question, or do you have any follow-up?
I have a few more questions. So, like, how is the process, like, different than I would get in an office? As far as, like, they hook me up, my arm. Is that the same thing that we would get at home?
Yeah, so at home, any one of our companies basically would provide the same service. So you'd be there, the drug would be shipped there, the nurse would show up. If you didn't have an IVIg in your arm, or some other organ was fixed or something, they'd put a peripheral line in, they'd infuse the IVIg. If you had 2 or 3 days in a row, you might elect to leave it in, and then cover it with like a protective device. And if they're not going to come back for a week or 2 weeks or something, just pull it out and not have to deal with it. So the nurse will come and do it. All of us probably have nurses that have a bunch of tablets or laptops that collect the data for the infusion. So want to know what the rate was last week, what the temperature was last week. We keep track of all that. So it's relatively no different, except we don't go into it. And whether or not there's 20 other patients or a benefit to you or a problem for you, plus the number. So maybe additional comments on that.
I think your general overall health has a lot to do with that decision too. If someone's sick and maybe compromised, maybe open to infections, or as we call it, nosocomial infections, may not want or may not choose to be in a hospital setting or a clinic setting and exposed to some folks that might be sick with viruses or bacteria. So if you're relatively healthy, that might be an option, but most people choose to stay in the home. And it's more familiar. You have the TV, no crowds, no parking. It's safe. The nurses that come out, any of our companies are all well trained. In the infusion suite, you may have one nurse caring for 5, 6, I've seen 16 or 17 patients with one nurse being infused. It's crazy, but good.
Yeah, I was just going to quickly follow up on the insurance question as you were talking about it. With one of the a company that specializes in IG, you should also be able to call them. They maybe have to ask for a patient advocacy department or the insurance intake department. Go through them to determine your benefits. They can do that work for you instead of calling the insurance. They can call the insurance company, determine whether or not you have home infusion benefits anyway, and let you know what your out-of-pocket may be. Another follow-up is for certain payers. The pharmacy itself may have some financial assistance programs. And so if you're really struggling with the $3,000 per month and you have the benefits and it's the right kind of insurance, that pharmacies are allowed to do that, you can sometimes get help that way too.
So one of the things I always was concerned about is how did you end up in that infusion center to begin with? Is your doctor who ordered the IVIg his or her infusion center?
Yeah.
Okay, so I don't want to make any further comment, but I'm always concerned because I may talk to a couple hundred patients a year that have some unusual thing going on, and I always try to figure out how did you get in the situation you're in, whether it be good or bad. And so normally the physician, I shouldn't say normally, but most times the physician has no interest in where you get infused because he or she's not involved. But if they do it in an infusion center, it could be a really good thing. They could have the best nurses there. You could have your monthly visit right there. There's a lot of benefits. But as John said, with the issue with infections and having people there, especially maybe lucky it's a rheumatology infusion center. Somebody else I was talking to earlier today is going to a chemotherapy infusion center. So your comments about other people being infected and other things like that are much worse in that kind of setting. And also in the rheumatology one, they're mostly getting Remicade, and that takes a couple hours, so they're used to that, how long they're going to be sitting in the chair, maybe 4 or 5 hours. And the chemotherapy one, they're used to turning people over like every hour. So you're sitting there for 5 hours, they're not very happy with you because they can do 5 chemo patients at a time it takes to do you. So I think it's a complex situation, and I'm always empathetic to how the patients wind up in the situation they're in, be good or bad.
He's exactly right. And the in infusion suites, the turnover is important. So if an IG patient is there for 4, 5, 6 hours, sometimes longer, it's not unusual. And anyone in here that receives IG knows that volume and rate of infusion is critical, especially for side effects. Yeah. So it's not unusual for the rate to be increased, without sounding cynical, to turn that chair over. So the chance of certain side effects are increased.
1 second, I'll follow up that.
So you folks, do you have employees in the states in which you do business, or do you have like a list of contractors that you feel comfortable with and you like contract the job out to somebody you feel comfortable with? Is number one. Number two, could you give me the name of the IVIg society or association that you mentioned? And let's say it's a little bit of a more complicated deal where, you think your insurance company isn't going to necessarily pay for it, may take some convincing. Do I give like a case manager or something to assign my case to one person who I'm dealing with instead of several different people?
And those are all excellent questions. Let's see if I can address them without forgetting them. First of all, so employees in different states that we service. So our company, we actively infuse patients in about 10 different states right now. In those states, we do have at least a regional nursing manager who oversees all the nurses in that area, who also infuses patients. They're experienced in IG, they're members of the society, which we'll talk about in a minute, and they're either certified or on the way to becoming certified in IG therapy. The second question was a caseworker. Yeah, very much so. So when you call the pharmacy and if you were coming to call and check on your insurance benefits, you have a complicated case. Maybe the insurance doesn't want to cover it because of your diagnosis or whatever it may be. That's why I think it is great for you to go through the pharmacy itself, because those insurance people know those things about those companies. And we have a patient advocate who handles a lot of that for us. And what they'll do is they'll handle every bit of that. They'll call in, they'll verify your benefits, they'll fight for that authorization. That's the reason why sometimes the infusion is not always right away, because sometimes that fight can take a while. But we will take it to the insurance company on your behalf to make sure you get what you need.
When you say we would call the pharmacy directly, do we call it some main national number for each of your companies, and you tell us the pharmacy in our local city to call?
Well, that may be different. With our company, you would call the main number, and our insurance department and advocacy department is centralized. So they handle it for every office. So you talk to one person there, and then we actually have 3 pharmacies. And from there, we'll determine where we'll service you from, but you'll speak with one person about your insurance. The society is the, earlier Bob said the IG Nursing Society. What used to be called the Immunoglobulin Nursing Society. About 5 years ago, they opened it up to pharmacists and nursing, which is so important in IG therapy. And so now it's the Immunoglobulin National Society. It goes by IGNS, they're meeting in Vegas. And it's something where they oversee the training of pharmacists, the standards, writing standards, to try to make sure so that you can know who you're working with in the home is familiar with that product, administering it, making sure that it's not administered too quickly. So that's the name of the society.
Anybody else want to comment on this, or is that okay?
It's kind of like 1940 changes back and forth, but at least we have a microphone. So I'd like to comment on the authorization process, because that's often the most surprising thing. So the normal process is that we get orders from a doctor, we get history and physical like you and I just talked about, and then that information is sent to the insurance company as a package, usually electronically, and the insurance company then evaluates that against its standards. And, you know, for example, Blue Cross of California or Blue Shield of California, whatever, they have standards for when they approve IG for whatever diseases, and they have a criteria. So it says you have to have this test, that test, you have to try this, you have to fail that. And so it's like climbing hoops in a circus to me. You have to jump through each of the hoops and not catch on fire before you get to the next hoop, and survive until you get to the last hoop and get out and get authorization. In the meantime, if your authorization is denied, then each company has slightly different rules, but they usually look like you have the line of appeal that can be done by the pharmacy on behalf of the patient. If that's denied again, then most insurance companies then they would have like a physician would have a peer-to-peer with that company, that insurance company. They would get a physician on the insurance side to talk to your physician, and usually that's a very arduous task to try to get a hold of the company physician, and that physician usually is not expert in the subject. So many times, most of our experience over yours, but most of the time when the physician does that, he or she will be successful because whoever's on the other end is really just holding one of those flaming hoops and trying to wiggle it when you come through it, but if the doctor can jump through it, then it's pretty much approved because they're never an expert in the environment and they're never an expert in their disease. They're typically a retired pediatrician or some other thing like that, nothing to do with neurology. So then there's one more final step, and it varies state by state. So here in California, there is a insurance department of managed care in Sacramento. And so several times we've written letters on behalf of the patient to them, telling them that we think that this is from the patient. The patient reads it, agrees to it, modifies it, signs it finally, and we send that in. And then in that case, the state can actually override the insurance company and tell them to do it. So it's not a good way to make friends and influence people. A lot of the time that we've been very successful, maybe 10 times in the last 2 years doing that. And that varies by state. I know we've done it in Illinois, I know we've done it in New Jersey, I know we've done it in Florida. So by the time all that happens, you're into it for like a couple months by the time that happens. And so you have to be aware it's a long fight and a lot of other people that will have to be involved in that case. So that's kind of the process. And as James said, most companies will assign you some sort of case manager. So it's either assigned to you by virtue of where you live, your zip code, your alphabet, part of your name, or something. And that way that person is the one who his or her computer is triggering every 3 or 4 days, like have you heard from Blue Cross of Illinois? Okay, and if they haven't, then they call them again. And so there's a mechanism, particularly the case manager, to make sure that you keep following up. And most insurance companies have some rule that they have 7 days, 10 days, 30 days, whatever, to make a decision. And so whether they stretch that out to the max or not depends on various things. So it's a complicated process, and I think that the pharmacy company, as James was alluding to, that does this day in, day out, is the kind of group that can help these things. If you don't get that kind of service from wherever you are, you should be asking, I need to talk to a second person all the time, I can't be talking to somebody different, who's managing my case. And you also have a pharmacist that's assigned to you, and John just said you should have a nurse that is primarily assigned to you. So that way, you have at least a fairly known commodity of people you're dealing with.
We have a question there.
Hi. So I've been getting my IVIg for about, I'd say 3 years or so, and I do 5 days in a row every 4 weeks. And it's amazing to do it at home, and I love it. And My issue is, and I know it's probably something that obviously I have to talk to my doctor about. Obviously, I can only make this decision on my own. But I've noticed that the nurse is having, and I don't want to scare any other patients in here, a really hard time accessing my veins. I had one nurse that took her like 17 tries. On average, I would say it's probably 6 tries each time, and I've been taking the IV out every day because I'm, you know, it's hard for me to do stuff around the house when I've got an IV in my arm and I leave it in overnight. So I feel like I'm ready to give up. Should I hang in there? I mean, or do you guys like, should I love my doctor, but he's a busy guy. You know, should I ask my nurse to initiate it, or should I hang tight? In regards to getting a port.
Okay, yeah.
We all answer back here. We all answer?
You want a microphone or you're okay?
Yeah, has your doctor talked to you about a port?
No.
Yeah, so I just had some conversation at our table at lunch today about that, and I think there's actually this patient here, if I don't give away your names, and I know it, but I can't give it away. So we find that IV access is a major issue, and the fact that if it's easy and no problem, that's fine, but if it's not, then there's two different schools of thought in the physician part, where they either think that getting the PICC line or a port is going to be somehow traumatic, and don't want to do it for whatever either infection or reasons, or they're just not familiar with it. And then there's a question about how many sticks. Our company, at the second stick, we have to get a nursing manager involved and other things. So we would never be getting, should not be involved in this stuff. I'm sure all of them are the same because it's part of the national standards. So, so I think, and most of the time, back to a physician, and I think it's difficult because we have relations with a physician, but he or she, typical one we get, says, 50 grams twice a month or whatever he said the dose was. And they don't tell us the brand, they don't tell us the nursing, they don't tell us the route, they expect us to manage all that. And so that's really the measure of your company that's dealing with you right now is, who's complaining about that many nursing sticks and what they can do about it. And you, of course, have the right to change companies. And just like you would with a rental car or something else, you don't like to do it. But that 17 is clearly, way, that would not be more than anybody that I know.
Yeah, that was just one time. Typically, it's like, I would say I'm like average 6.
Oh, yeah, but still certainly.
Yeah. I really like my nurse at staff.
So the nurse isn't the problem. The problem is the physician not honoring your wishes to put a port.
I haven't asked him.
Okay.
I am so stuck between thinking I'm so young and I'm afraid to get one, but then it's getting to the point after 3 years, and this is going to be going on indefinitely because my disease is just not budging. I have dermato, so
Subcutaneous.
Yeah.
Subcutaneous.
Well, then how long do you have to sit there? Because my infusions are long. Oh, sorry, my infusions are 50 grams each day for 5 days. So where does it go when you put it sub-Q? Like when my vein blows out and it starts going,
Fatty
it hurts.
tissue. Fatty tissue.
Okay, James, why don't we go up front?
Yeah, just let me, one other question. So 17 tries is, like I said, is unacceptable in the industry anywhere.
Yeah, that was
Would any
rough.
physician let his wife or her husband be stuck 17 times? And the answer to that is no. And with all those sticks, your veins are going to continue to get very sclerotic.
Yeah.
So you really, I don't think you have any options. You really need to consider, this is just my opinion.
Yeah.
You need to consider a port because at some point, you're not going to have any access.
Yeah, she's having a hard time hitting my ACs. Those are even collapsing. I don't know if it's my disease or if it's just I've been stuck too many times.
Yeah.
So, thank you.
So I was getting excited there because I was kind of jumping at the bit to hop in there. So, because I do think there's an option,
Yeah.
okay? And now this might not be something that right away your physician gets excited about when I mention this, but yeah, Subcutaneous, okay, comes out as subcutaneous administration. Do not have to access a vein. It's been approved for primary immune deficiency, and they get much lower doses. Okay, so the problem has always been with autoimmune diseases such as myositis we need the higher doses. And can we get that much fluid subcutaneous? But there is some studies being done there. Some of the manufacturers here are looking at that right now. We have many patients that we're doing subcutaneously successfully who have myositis and are receiving high doses. John Hopkins is someone we're working with, the Myositis Center of Excellence there. This is something they're really kind of getting into. And we've been successful, so that's a whole other fight with the insurance, but we've been successful in a lot of patients getting that approved. There's some great studies out there that support it. IGNS, if you'll look at the standards with IGNS and they get to when IVIg is no longer really an option, the recommendations there are consider sub-Q. It's great options for these patients. I think it's a possibility for you. What happens is you still need to get that dose in over a month.
Right.
Well, with subcutaneous, to get that dose, what it may take is once a week or twice a week infusions. Usually they're only an hour or two, and you can even do them themselves. Another benefit is the adverse reactions are typically a lot less, although you'll see a lot of local reactions. Some people do have problems with the subcutaneous administration, but consider that. If more information, I do have some studies I can share with you.
Okay, thank you so much.
So, I was going to comment on two things. One, the fact that, again, about the cords and things like that. So this young lady here asked what's a cord, so I guess we should clarify that. So normally that is a peripheral catheter stuck in there, and a cubital, like you just mentioned, that's in and out the same day, not a big deal, can last for 3 days. But there is such a thing that's actually, and there's a PICC line, which is a peripherally inserted central catheter, which would go in here and would basically be fed up into episodic part, and that can stay in place for several months and offers lots of benefits, but it's hanging out. So then there's a version of that that's inside, and that can be a port. And there's one that brand names is a port calf, and there's other others. But it basically looks like about the size of a 50-cent piece. Maybe too young for that, 50-cent piece, and it's about maybe it's like a half an inch thick, and it's surgically implanted. And it has a rubber cord on the end of it, and you can put a target on the top of your skin, clean the skin off, and there's a special kind of needle that goes in that called the Huber needle, and then that can stay accessed for one dose, or it can stay accessed for a month, and you keep flushing it, and whatever else you're going to do with it. So that way, when you're done with the infusion, you pull the needle out, except for the lump there, you can't really tell. So it's not for everybody, and we have, at least in most of our pharmacies, we have at least one physician that is a vascular specialist that puts those in. So we get around the problem you're having, you may have, when you finally bring it up, that the physician may not want to do anything with it. You said earlier, because you end up getting a referral to a physician who does that for a living, and then he or she will be responsible for putting it in, as well as maintaining it and running the orders that go with it.
So let me, we'll move on to the next question, but I have a question first for the folks in the room. The questions that are being asked now, I know we have a relatively small subset of people, in here, all the people that are at the conference. Were you aware of the information, majority of the information imparted from the last question, so it's new to you? Is some of this information new to you? Okay, I'll tell you why I'm asking this, okay? Because, I head up the entire South Florida, region for the Myositis Association, right? So I'm just listening to you guys and I'm saying, hang on, if this small subset of people in this room have this many questions, then if you extrapolate that to how many people are at the conference, how many people are in the United States. So my perspective is from our charter as being supplying information to our members. So maybe you folks that are your group and your people, maybe we ought to chat over the next day or so. I need ideas on how we can disseminate this information shorter, sitting here in this room. Certainly it's being videoed, so on and so forth, but we want to do it actively. And you guys, we'll start off, at least please, you have my card for the South Florida region, so I want to get your folks involved in our meetings down there, and we want to actually expand that to, to the rest of the country also, okay? Because I'm quite surprised at these kind of questions from such a small subset of people. We're going to have this question, then I'm going to come to you.
Hi, I've been having infusions for close to 3 years now. Okay, My infusion is up to 90 milligrams, and it takes around 8 hours to get done. And before I do the infusion of the IVIg, I take Myositis. Okay, and that takes about an hour to get done. So we're looking at about 9 hours. Okay, so at first I was having it done through my private insurance, where I was going to the doctor's hospital in New York City, and they approved me for home infusions. Okay, but then the VA took over because of my condition that I had, so now I have all my infusions done at the VA. But we're talking about, I get there at 7 in the morning just so I can get a good spot. And then, I'm there for, 10 hours, and I'm trying to get them to give me home infusions because of the fact of the amount of time that I'm spending there, especially in the wintertime. When it comes to wintertime, and you're talking about that I have to deal with the snow and the rain and the cold to get to the VA and then get back in the car and then drive back home. So what is your involvement with the VA and how successful have you been to try to get them to give us home infusions? Because my social worker has been battling with that to try to get them to approve it. But like you said, that it's less expensive to get home infusions than it is to get it done in the hospital. So,
Anybody want to take that question?
no, VA take care of it.
So, let me see if I can't see you, I'll just lean over and see between these two people. So, our company's been doing this for about 7 years now. We've been trying to interact with the VA for all this time. And so without being, negative to the VA, because I think they provide a great service, they have a lot of good things going, they're really not geared up for much outside of their own building. And when you think about cost of the VA, it isn't like a real hospital. Like the normal, because most people, even though they get paid, but it's just not like a normal hospital. So if you're, we've been unsuccessful except for acute therapies like IV antibiotics and things like that to get much business out of the VA. I've been to Washington D.C. lobbying, I've been meeting with senators, representatives, I've done a lot of things and never got anywhere. So I think what you're describing is a very normal thing. In fact, I think your thing is actually good because many places, the VA infusion center only does chemo and they only have openings for IVIg on Friday or something, and you have to get in that or you don't get it up. So depending on your insurance, and I was talking to somebody earlier today about the VA as a benefit, and it has a lot of good support, but many people don't realize, and you do, that if you have other insurance, you can use whatever you want, whenever you want. So the VA, a lot of people use it because they think that it's not going to cost them anything, and they can hold the other insurances in reserve, so to speak. But in many cases, if you're up to the point where you don't like it, you're going to have to pull out one of the other insurances, you're going to have to cross it from shield or something. So the VA is a great benefit, but it provides a conundrum for certain things, like what you're talking about. My experience is what you're actually experiencing is good for the VA, so I just want to link it up.
Just a question, what is your insurance? Is it Medicare, is it TRICARE?
No, everything is done through the
Everything's done
cover
through
everything for you. I mean, it's financially it's fantastic without paying anything. But
The process itself is cumbersome.
The reason why the VA.
I mean, I have Medicare to my disability with Social Security. But the VA handles everything.
Can't do it home. Medicare you can't, and you're able to leave your home, so. There's a person, I met someone from the association.
Right, there's a section on that.
That represents the VA system. I'll talk to you after this is over. I'll see if I can help you with that.
I'm retired military.
Hold on, that's we'll get one. Go ahead.
So the reason that the VA, sir, so because your VA primarily, that's your health care, the system is designed to turn turn things over for the members, because I'm retired military, they're gonna keep you in there because it's cheaper for them in the military system than it is for them to provide you home care through other companies. That's the difference. Now, if you were TRICARE Prime, retiree TRICARE Prime or TRICARE for Life, those kinds of things, it'd be slightly different. But because it's through VA specifically, that's why they're keeping you at the hospital. It's a financial thing for them. And we can talk. I'll talk to you more.
Real quick, this is something I'm really positive about. But I would meet with some of the insurance people here. I don't know if Part D is an option in this situation. If you have Medicare, Part D is not an option. But yeah, I would definitely ask some insurance people to check into it. We have had patients with the VA with what we call VA pay, and but that has been mostly acute therapy, like you mentioned. So, but you know, it's worth a shot. Have somebody take a look at it, call, let's see what we can get done.
The good news is you're getting relief.
Yeah.
That's
a great point.
The question over here.
As my wife mentioned a few minutes ago, we had questions about our IVIg provider for doctors or Hopkins, and the end of the provider doesn't give the level of care you all would do. How do we check which providers to go to, and are the out-of-pocket costs for us? We're on Medicare with AARP, United Healthcare supplemental, which I understand probably pays nothing to cover under Part D, so we're the 20% out of pocket. That's the first question. The second question is there's different brands of gabapentin, and we don't know one from the other. The doctor didn't prescribe any particular amount, left it up to the pharmacist. If there's something there that we should be concerned about.
Okay. Yeah, so you hit my soapbox with the second one. I mean, that's my.
We're going to keep it under an hour.
Yeah, so I have to keep it low, but that's where I really get excited talking about product selection. But first of all, so you're at the Johns Hopkins Myositis Center of Excellence, Maryland.
Yes.
Okay, you know the case managers there, any of the Anastasia, those type of people.
No, I just work with the doctor.
Okay, well, so that's easy to know. So you can give them, you can find a provider that you would like to use, and you can go to them and say, do you work with this pharmacy? I would like to consider switching my treatments to them.
Right.
And they should take care of the rest for you. So that's one answer to that. So product selection, in general, and I'm going to make it quick, we have a lot of different, we're fortunate that we have a lot of different immunoglobulin therapies out there, a lot of different IVIg brands, and that's not always been the case. The period in 2005, we had a shortage that was pretty difficult, and a lot of people really suffered, and some people even lost their lives during that time. But we are blessed right now that we do have a wide selection of products and availability. So generally, they're considered all equally effective or efficacious. So to answer your question about that, in general, they're considered to have the same efficacy, although some have approvals for some diagnoses and some for others. However, they're all formulated very differently. And the differences in the products actually have an effect on how well it's being tolerated for someone. So some people, for instance, one of the products is stabilized with sugar, and that's very hard on the kidneys. And if you're someone who already has kidney function that's declining, probably not the best product to go with. We need to go with something else that's amino acid stabilized or what have you. And that goes for a whole host of different diseases. So when the pharmacy gets that order, what they need to be doing is, first they have a conversation with you, but they need to go to your electronic medical records. They need to look and see what other diagnoses does this man have, and what would be the best product for him. A lot of places, sadly, will basically solely on what they make the most money on. It doesn't need to be that way. We need to try to select a product that works, that we feel will be the best case for you. Now, everybody's very different. And so sometimes our selection doesn't work out the way that science says it should. And in that case, we're gonna work with you and find a product that does work well.
You guys agree with that?
Yep. Just one other thing. That's not, I think you may have considered that a negative, that the drug wasn't prescribed by the physician. Is it?
The drug was.
It was prescribed. The brand, I'm sorry.
Not the brand,
The
no.
brand wasn't. That's not, I'll be honest with you. I think it's a really positive thing, because the pharmacists that work with patients on a daily basis and have access to the medical records are going to look for those things where, in a busy practice, if someone has a problem with kidney function and is given to them, it could be a problem. They're going to pick that up. That's going to be one of the first things they look for. So, product is that's a good thing.
So just to, I'll let you go. So, are you saying that if she comes over to one of your companies, you guys will look at the most efficient and the most cost effective? But I'll let you go ahead and answer what you said.
So if I, on one of John's comments, so the chance that any physician is going to prescribe the most clinically and economically beneficial IVIg brand for your patient is pretty low, because there's so many variables to take into account that are clinical and financial. So all of our companies would be looking at that, and we all have different algorithms that we custom made that are able to figure those things out. And as James mentioned, there's a couple of products that have some excipients and things in the maple liquids or maple powders. That could be something you have to consider. For most intents and purposes, they're probably 95% the same on the brand. But just those 5% that's different, because they both all contain the same things. Basically, everything in the blood is pooled and donated. So back to the company then. So as James suggested, you should be able to call your doctor's office and talk to your office manager or whoever the practice manager person is there, and say, I'm not happy with this current company, and you should either ask them, who else do you use, who else are you happy with, and or you should have a list of people you can check on the internet, you put in your zip code and say, infusion companies near me, will pop up rapidly on Google, and you can look at their information and at least be aware of it. Because if you call your doctor's office and they say, oh, we want to use this company XYZ, you wouldn't know if that's any better or worse, and they may have good experience with them or may not. So you're the one that should have a choice. And back to your opening question an hour ago, the fact that you'd be asking that question is, this is very unlikely.
It's typically the cost the same.
Yeah. So we all get paid the same amount, basically. So for example, we might all have a contract with Blue Cross or Illinois.
This is Medicare.
Okay, the Medicare, we all get the same price, so it's no difference.
So the 20% to us would be the same to you.
Yeah, I mean, the way, at least that's one good thing about Medicare is everybody gets paid the same. I don't know how much it is.
Right. And it's Part D, it's not necessarily 20%.
Yeah.
Okay, so it may be a lot less than that.
So I think that's part of our problem is that we have to talk about, a lot of times I spend on the phone talking about Medicare A, B, C, and D, because most people, they say Medicare, and that's what I'm referring to. So if you're referring to Medicare B,
I think that's what covers IVIg.
but not at the home. Not for your diagnosis, not at home. So you must be using Medicare Part D, like the Express Scripts or something like that. And then that Medicare supplement you have doesn't cover anything for the Part D. So it's very severe in the doctor's office, it's different in hospital, different. So it's a very complicated situation. That's part of our company's expertise, I guess, is going through that minefield of every patient that comes along.
Okay, guys, we are at the end of our time, so, but I do want to go back to the topic that I'm listening to these questions and I'm awed by these questions and awed by your answers, but it is a complex process that you have to traverse. But generally people just go, whatever the doctor says, you follow that. So we should come up with some sort of, if we go to your website, is there guides there as to what a person should do? And then is that something that us at Myositis Association, should we take that and just sort of create a guide, for the membership? Would that be beneficial to you? The process?
Yeah, the doctors don't know and don't have time.
Right. So I'm going to repeat again, because if you guys, the whatever 25, 30 people in here, if you have that many questions, you know, they're repeatable, and then there are a lot of other questions that we did not attack. Okay, so we'll take that on, you know, that project on. I will need help from you guys. You know, certainly we'll put the resources on that, and we'll put a guide together. Okay. So thank you very much, gentlemen. Thank you for making the time available to us. Thank you. Okay. Appreciate it very much. Please make sure you fill out the eval sheets for the session. Okay, because that helps us a lot in saying that, okay, if this is valuable, then we want to make it available again. Thank you. Thank you, guys.
My name is Chris Harris. I have dermatomyositis. I was first diagnosed in 2005. So this is my 12th year, and this is my first year to this meeting, which I'm kicking myself for, but going forward, I'll be at every one. My favorite part of this meeting is meeting the patients and their advocates, and I'm amazed at the support that I've received since I've been here from everybody. And I love that people have shared their stories, no matter how challenging, but I love the idea of hope for everybody. And my second favorite part of this meeting is the individuals who have donated their time to move this disease forward and try to find a cure, which includes everybody with the Myositis Foundation as well as the panel. Every person who has volunteered their time, the physicians, the physical therapists, the volunteers, and the fact that they've committed to do this as they move forward is amazing to me. And I love it, and I will be here again next year and the year after that. And it just gives me a lot of hope when I was very depressed. So thank you for inviting us, thank you for supporting it, and I look forward to seeing everybody next year.
Hello, my name is Anastasia Victorson, and I came here all the way from Stockholm, Sweden. I'm very happy to be here.
Is this your first time coming to the Myositis?
To this conference, yes. To the TMA conference the first time.
What's it been like?
It's been fantastic. Very informative. I've met my friends, my Facebook friends, and I hope I'll be able to come again. I have polymyositis, but I also have a syndrome that's called the anti-synthesis syndrome. I have antibodies, a lot of them, but anti-Jo1 is the most common one. And I also have ILD, quite serious. But getting medication, feeling quite okay. The doctor saved my life. Yeah, very good information. And it's also nice to see the persons. I read a lot. It's also nice to see them in real life, to be able to interact with the doctors. Yes, I'm just happy to be here, having met you too. Take care. And everybody else that hasn't been here, hasn't gotten a chance, please try, because this was really worth it. It's beyond my expectations, really. Thank you.
Hi, I'm Doreen Cahoon, and I am on the board of the Myositis Association, and I've been coming to the conferences now for 7 years. I got involved because I lost my father 7 years ago who had IBM, and my sisters, my brother, and I wanted to get involved, and we love every year coming to the conference, meeting new people, and always impressed with how strong and wonderful everyone here is that we meet, and just like being able to help out. So I've enjoyed being on the board. It's a wonderful group of people, all very strong. You know, it's easy in the end. It doesn't take up a lot of your time, and it's very rewarding. So I enjoy it.
So you just heard from my sister Doreen, and I'm Darlene. So Jack Weinsheimer is our father who had IBM. And as she said, we lost him 7 years ago, but coming to this conference every year means so much. I love the people that I get to meet and talk with, and I so wish that my father could have attended. I know that he would have loved getting to be with other people that had IBM, just to talk about the experiences that they're having. So I look forward to this each year and just helping, and I just love the people that I'm with.
I'm Alexis Redmond, and I'm from Salt Lake City, Utah. I have IBM, and I am here to meet other people that have myositis and learn from the experts. I appreciate the TMA and everything they do for us.